Okay, so over to you, Kathy, for the moderation. And I see Elvis is right online and the other moderator today. Before I hand over to Dr. Kat, it's a very special day at the town hall. And we are here really to talk about one of the things that I hold very dearly to heart, that is cancer care. And to get to understand, I think from my perspective, one of the biggest health system that has devoted a lot of time, and an incredible physician too, who has devoted a lot of time with her team to help us really get to understand cancer care in a developing country, and also despite the lack of or limited resources, they are doing a wonderful job. So today we will get to see what the Mbingo team is doing when it comes to cancer care. So over to you, Dr. Kathy.
Thank you very much, Mano, and thank you everyone for joining in on this particular day, and welcome to another edition of the Cameroon Town Hall. And as our chair rightly said, we will be discussing cancer and cancer treatment in Cameroon on this particular seminar this evening or morning, depending on where you are joining us from. And so I think we actually are looking forward for a very, very interesting and insightful discussion today. But before I go any further, we are kind of short of moderators today, but I think we're going to do a good job anyway. I don't know if Elvis can speak where he is. I can probably see is he driving or not? So
no, sure.
Okay, that's great, Elvis. So over to you, just to hear your thoughts on this particular session this evening.
Thank you very much, Dr. Kate, and thank you, Chair Mono. Thank you. Greetings to everyone for joining this edition of the Town Hall. I'm very confident that we are going to have a very exciting topic because it falls in line with the area of specialty of our chair. That is, as a hemato-oncologist, I know he's going to be very excited to listen to this presentation. But equally, I'm very excited to just learn about cancer care in Cameroon, and from those who are doing one of the best job in this domain in Cameroon. And so I think I would really be a student in this, as usual, in this session. I'll soon be on my desk in the next 15 minutes so that I can have my pen and paper. But trust me, I'm really excited for this edition, and welcome to everybody once again.
Thank you so much, Elvis. It's rather unfortunate that we will not wait for you to get to your decks. We will continue. And well, in fact, usually when we hear of cancer, everybody gets scared, because of the challenges that come with that particular diagnosis. Even with regards to diagnosing cancer, we know it can really be problematic in our setting. And Dr. Kouya Francine will be giving us a treat. So, but before we go over to her, I would go back to Mona, who is our chair, who is actually a subject matter expert. Another way of saying that he's a specialist in cancer, in oncology, certainly. And just really to tell us about what we are going to have for this session, and also to present Dr. Kouya Francine Kouya. Thank you.
Okay, so Kathy, thank you very much. And I'm very excited today, not only because the diagnosis of telling someone they have cancer, especially in Africa, is a taboo, and everyone really gets scared and people think about dying. That's the first thing that comes in mind. And I think after knowing and watching the Mbingo Baptist Hospital, what they have done, they have built an incredible team around the management of pediatric and both adult cancer diseases. And this is usually a multidisciplinary team. And cancer is just one diagnosis. There are multitudes of diagnoses. So today, we're going to have a very special guest with her team that they will tell us exactly what is going on and what they are doing so that we can enlighten the population and also get others to be able to collaborate, especially those who are in the diaspora. There are a lot of people in the diaspora here who think or who are thinking of wanting to help back home and where the help should go to. And I think Mbingo is one of those places where they have a whole team built up, made up of physicians, made up of specialty pharmacists, made up of social workers, nurses that are around this team doing a wonderful job. So today, the lead of the team is Dr. Kouya Francine. I have known Dr. Francine for quite a while now, and she is a stellar physician, an excellent physician who is trained in medicine, first of all, and she's an internist. And she had her training in one of the prestigious universities in South Africa, Stellenbosch, in oncology. So she's an oncologist, been practicing oncology for many years, despite the challenges that we do have in Cameroon in terms of diagnosing, in terms of pathology, in terms of imaging, in terms of access to medication. She's doing a wonderful job, and she has multiple presentations that she has done, even at ASCO, in order for us to integrate cancer care in developing countries, even at the level of ESMO, ASCO, and all of that. So she is a seasoned specialist in management of cancer, both in the developed world and also coping on the developed world. And with the little resources that she has, she's been able to do a wonderful job. But I think their team will need a lot of help from those in the diaspora who are willing to collaborate and to help and foster what they're doing. So I would like to, with your permission, Dr. Kate, hand over to you to be able to pass over the mic to Dr. Kouya Francine.
Thank you very much, Mona, for that really prologue or introduction to what we are going to be having this particular evening. I really want to say welcome again to everyone joining us on this particular edition of the Cameroon Town Hall. We are always so grateful to see you joining from multiple regions of the world every fortnight for these particular discussions that we know are helping to improve healthcare in our country in one way or the other. So we would be passing over shortly to Dr. Kouya Francine. I can see a lot happening from her side. I hope everything is set. I think they have permission to share screen. Yes. You do have permission to share your screen.
Yeah. So while waiting on Dr. Francine to unmute and share her screen, right, it's very important for us to know that they have been doing this for quite a long time and really taking care of cancer patients for a very, very long time. So over to you, Dr. Francine, and your team. And also for her, this is it's important for us to know that those who are here for the first time, the town hall is a wonderful group that was created almost 3 years ago, where those healthcare professionals in the diaspora and those back at home can be able to collaborate and discuss different topics when it comes to deal with healthcare problems in Cameroon and create collaborations that can also help to ameliorate healthcare in Cameroon. The other thing is important for us to know is that the town hall right now, we have had the Minister of Public Health here multiple times, and we are presently engaging with the ministry in order to discuss ways on how to foster and get the diaspora to engage in healthcare in Cameroon. And last week we did give you updates about that. So over to you, Dr. Francine. I think Elvis is also settled in his office. That's great.
Great. And I mean, to those who miss that particular session, I think it's going to be uploaded.
Yeah, Dr. Francine is talking. We can get her.
All right.
Okay.
Okay, so good afternoon, everyone.
Yeah, good afternoon.
Thank you so much for giving.
Yeah, your volume is extremely low. Yes, Kathy, while they get the technical issues sorted out, we're used to this, and especially network in Cameroon is always challenging. So I think this is going to be sorted out. And
yes, definitely. And it can be also challenging. I hear currently in Yaoundé, there's been a really heavy downpour. So, you know, under such conditions, network can really be challenging. Slightly better. Can you probably either increase the volume of your laptop or probably just go very close to the mic of the laptop?
Okay, is it better?
I think it's coming, probably 6 on 10. Can you?
Okay, is it better?
6.5, it's increasing.
It's getting better.
Okay?
Yes,
yeah, that's
getting better. Yes.
Okay, yeah.
I think we can manage
so
that.
I will
Thank you.
just be close to the the computer. Okay. So thank you so much for giving the Mbingo team this opportunity to present what we are doing. So it is really, I think it is really an honor to share this, what we are doing here in Mbingo with our colleague, with the diaspora, so that at least people, our colleague, our brothers, they will have confidence that despite the limited resources, we can give family hope. We can give families an opportunity to care for somebody with cancer so that the person does not die with suffering, with misery. So the next slide, I'm going to share what we are doing here in Mbingo. Okay, so Mbingo belongs to the Cameroon Baptist Convention Health Service. It's a faith-based organization.
Yeah, we can get you.
Organization, over 70 years of existence. The main thing that I want to talk about in this slide is that the mission statement of the Cameroon Baptist Convention is exemplary care to all who need as an expression of Christian love. How do you do exemplary care to all in a country where we don't have health insurance, where people are living with less than $1 a day? It's very challenging as a mission statement. Sorry, so MBH Mbingo is the largest of 6 hospitals run by the Cameroon Baptist Convention Health Services. So it was initially a leprosy settlement. That is why you see this big, beautiful picture in the valley, because you remember, if you know the history of leprosy, anytime that there was a hospital that was treating patients with leprosy, they were isolated. They were isolated. As Mbingo here, it's isolated. That is how Mbingo is found in the valley. So when the cancer management started in the Cameroon Baptist Convention in Mbingo Baptist Hospital, it dates from 2003 with the creation of childhood cancer program through via Stellenbosch University. In 2007, cervical and breast cancer screening started within the Women's Health Program. And in 2010, a pathologist joined the team. In 2017, an adult oncology unit was established. So this is the team that is available in Mbingo. So I just want to underline the important points. Today in Mbingo, we have 2 pediatric surgeons. We have 2 pathologists. The second pathologist just came 2 weeks ago. So now we have 2 pathologists. We have a radiation oncologist, Dr. Tumsi. He's completing his radiation oncology in South Africa, Stellenbosch University, and he's coming back in, I think in December. We have a trained pediatric oncologist, Dr. Kifem. She's currently in India to complete 2 or 3 months before she's back to Cameroon. But this is the rest of the team. The other one that I've just mentioned here are those new physicians that have been trained so that they will come back to Cameroon and continue the work. So when we are talking about cancer, you know, many people think that it's a death sentence. We thought that it is important for us to start with a success story so that at least people will be encouraged. We have this adolescent that went round, and finally she landed in Mbingo. She has this massive facial tumor. She has a biopsy. They didn't have money. They spent all the money to do all the investigation. This patient was so sick, obstructed. So anyhow, we discussed with the family, we did everything with the family, discussed about the diagnosis. They consented, and we started her treatment. I think the second picture that we see is probably maybe after the second chemotherapy before she went for surgery. So this patient was treated in 2017. This is the same patient that I've shown you. So the tumor got finished, she got the surgery, and this is the patient today. So the patient is doing well. So just to encourage everyone in this forum, it is possible to give a chance somebody to survive, even with limited resources. This patient treatment was chemotherapy. She has a massive surgery that deformed her face, and then she also have radiotherapy. So she's now, I think, 6 years survival. I want to share the story of this child. This child came in Mbingo in this condition, massive abdominal distension. I hope that the volume is good. Okay, good. Massive abdominal distension, massive pedal edema, malnourished. When you look at the arm of this baby, of this child, you see that it is just bone and skin. High creatinine. So when we saw this patient, we asked ourselves, what are we going to do with this child? We did abdominal ultrasound, huge retroperitoneal mass, compressing with the ureter. So I discussed with the pediatric surgeon, is it possible to do something on this child? So yes, despite the fact that the child is very sick, I can do an ureterostomy. When he did the ureterostomy, I discussed also with a nutritionist, because I can't go ahead when the child has a biopsy, ureterostomy, the creatinine went down, the kidney function improved. They say, okay, we can do something for this child. The diagnosis came out, rhabdomyosarcoma. And you know, in this setting, in Africa and low middle income countries, you run after life, like this child. You have to speed up the diagnosis. Sometimes we have to ask the pathologist, please, the life of this child is in danger. We need the result now. So they have to speed up the results and they process and they give us a preliminary result. So he has a preliminary result that was an adenomyosarcoma. So when the pediatric surgeon did the ureterostomy, the kidney function improved. So we started his chemotherapy by giving him 3/4 of his chemotherapy, because giving him 100% of his chemotherapy would have killed him. So this patient received chemotherapy. Great improvement. This was just so striking, so encouraging for all the staff. And I remember one of the staff told me, you know, doctor, if this child dies now, you are fixing. Our aim, we discussed with this mama that we are not going to cure this child. This is palliative chemotherapy. Because the child does not need, because the child is born in the northwest province of Cameroon, this child, it does not mean that this child needs to die in agony, in misery. We need to give back dignity to children, even their parents. So this child received chemotherapy, gets well, the tumor shrink completely. The surgeon went back and removed the residual disease. When you see on the right side, this is the child and his grandmother on the day of discharge. So Joe, we are showing this picture to really encourage each one. It is possible to give dignity, to return hope. This child died 3 years after. Of course, it was surgery, it was chemotherapy. We don't have access to radiotherapy. When we did his surgery, he was having tumor on the margin. Of course, that was a sign that it is going to come back. Of course, it came back 2 or 3 years after. But at least this mother saw care. And also, it's helped to remove the guilt in the heart of the parents to think that this child maybe died because nothing was done. This lady saw. Another important case that I want to share here, this is an adolescent, I think it was 18 years old. This patient came with a huge tumor, osteosarcoma of the shoulder. He couldn't eat, he couldn't bathe, he became depressed. He was just a very difficult patient. We met them, we discussed with the surgeon, with the entire team, what are we going to do? The surgeon said, if we ever operate, we are going to operate, it will be, the margin will be positive. Then I said, no problem. I discussed with the surgeon, we discussed with the family, and everybody consented. We started with neoadjuvant chemotherapy. Good shrinkage of the disease. The adolescent was so happy. He could now go to the bathroom on his own, eat on his own. That was just good quality of life. The counseling of this family was that this child, he's not going to make it because it was so advanced, but the family was happy. So I think that this was his last chemotherapy after the amputation, and he completed his chemotherapy. This is a child who was so happy communicating with us. He died maybe 6 months or 1 year later. You know, I'm so encouraged to share this news. This adolescent did not die in misery. He didn't die in agony. He saw care before he left this earth. This old lady, I think she's 80 or 75 years old. She has massive vaginal bleeding because she has cervical cancer. They were having transfusion on a weekly basis. I discussed with the family, said, we can't handle Mama here in Mbingo. Mama needs to go to Douala for radiotherapy, palliative radiotherapy. The family had a lot of arguments. She's old. They don't know anybody in Douala. It will logistically is challenging. I say, we are not going to transfuse Mama every day. You have to go there and they are going to give the radiotherapy. She got the radiotherapy. This is Mama 5 years after. No bleeding, no transfusion. You know, we know that it's palliation, but the family is so happy and they gave me this picture. They say, you use this picture and show to the people in the world that something can be done. The last patient that I'm going to present here is this young patient. He got this massive tumor, crazy tumor that forced us to do what? To do a G-tube. He couldn't swallow water. He couldn't eat anything. And he was so emaciated. So we decided to place him a G-tube. Before we went to that decision, this family, they have family member in US. He has the passport. They have made all arrangements with the biopsy that they were having, that they want to go to US. But that week, the border were closed because of COVID. So Professor Talk who was his surgeon, told him that, you know, you better accept Francine to give you chemotherapy here in Mbingo. We gave him chemotherapy. After the chemotherapy, good response. After the chemotherapy, what happened? This patient now went for surgery. He has a massive surgery. If you see this patient, this is a patient with me after, I think, the second year follow-up. So he's not the second year after follow-up. He got a chemo surgery, massive surgery that deformed his face. And when we did the follow-up, he asked us why I didn't have reconstructive surgery. We told him that, you know, you were saving your life. We couldn't do reconstructive surgery because you have massive tumor. So this is the patient follow-up, 2 years follow-up. So I thought that it was really important to bring this picture so that the audience should know that there's hope. We can survive cancer. Even if we don't survive, we can give good quality of life to patients so that our family member, our brothers Cameroonian, not because you are born in a limited income countries, they will not die in misery. So we have, how is our services are divided here? We have the pediatric unit, 10 beds. We have 2 isolation rooms. We provide inpatient and outpatient, parents' home. We have a play therapist. So these are the treatment that we are doing, and I'm not going to go through all this one. What is important is that if you have all the chemotherapy, if you have all the trained people, if you have all the money that you have, and you don't bring support, it is impossible to treat cancer. We have patients that stay in the hospital 3 months. So we need to improve the nutrition. And some people, some family are coming to the hospital. We discuss with them, Mama, you know this child, this tumor in the abdomen is a Wilms tumor. Mama said, no, doctor, you know, I have to go back, I have to prepare. We know that we are running after life. Say, Mama, you don't need to go to prepare. This is a towel, this is a bucket, this is a cup of, this is milk, this is, so we have what we call a welcome packet. This is eggs. And we have also some money that we give them and say, Mama, while your family is preparing in the village, this is your welcome packet. We also provide transport support. We know family, they don't have healthcare insurance. And you treat a child, the tumor disappears, they go back to the village. Are they going to use the resources that they have to pay for the transport to come again when the child does not have the same income or follow up to continue chemotherapy? Usually it's impossible. So we pay for the transport. We also work with, we have worked with Sajuka. We also have metronomic treatment for parents, for patients who are not responding well. We have a parents' home in this hospital. The parents' home is helping. If a child has maybe a weekly treatment, so they have to stay in the parents' home so that they continue their treatment. We have curriculum to improve the nurses. We are also part of the supportive care for children with cancer in Africa. We are working with the National Cancer Control Committee. We are not doing our own thing in Mbingo. We want the nation to know that something is happening here in this part of the country. We have established a Cameroon Pediatric Oncology Group. We have had discussion with the Ministry of Health to lobby for childhood cancer. We have had collaboration with Yaoundé, the foundation, the Shanta Foundation. And also we have planned for regional hospital-based cancer registry. So who are our partners? We don't have our own protocol. We are working in partnership. In fact, you can't work cancer in isolation. We know about all the group. We know about children oncology group. We know about UK cancer. So it is impossible. Even now in South America, they are coming together. Because if you come together, you have gigantic data and you can make a decision. So we work with Stellenbosch University. They review our protocol, come to Cameroon twice a year. We work also with Berry Taya Memorial Africa. They were providing for drugs, the hospital in Leeds University and World Child Cancer. They provide money for parents, social support also. Vascular Oncology, International Pediatric Oncology Society, and those other organizations. What do we do? Treat somebody with cancer. You need to follow up. You need to find out what is happening. They say that the battle of cancer is not over even after treatment. So we follow up these children. In 2013, we follow up 96 paraplegic Burkitt lymphoma children. So what has really happened? Because this is stage 4. Maybe all those patients, they are dying. So they went back to the bush, follow up those patients, and we saw that 33% of those children were alive. In 2014, they went back to the bush and said, okay, we need to find out what is happening with these children. They went to the bush and found that 815 patients were alive. So in 2017, we are giving chemotherapy to these patients. In other countries, when they give chemotherapy during survivorship, they need to know what has happened, what is happening with the side effect. Usually we don't know, so they have to follow up those female survivors, find out what happened. Are they able to get pregnant easy, so that we cannot measure some level of toxicity. As I was talking about the follow-up, we do follow up. We go out, what has happened? So this is me on the bike. I went to a village to look for one child who has bilateral. Anyhow, I'm doing a survivorship clinic, so I usually go out. This child, I went to the village. Before I went to the village, I contacted the family. I said, I'm coming to that village. And the family told me that, you know, doctor, you can't come to our village with a car. You have to take a bike. I said, no, I need a car. They say you can't come there because the road is like very bad. So finally, I took we were 3 of us on the bike. As you see here, I'm in the middle. And then if you see, look at where this family is coming. This is a house in front. If the treatment were not free in Mbingo, I'm sure that this child that you see with her mother, she came to Mbingo, bilateral retinoblastoma. The sites were lost. If you see the left eye, the right eye, you already see a squint. So this child has bilateral enucleation. So they went home, and then we needed to know, how is the child is living? The bilateral retinoblastoma, is she in a specialized school? We needed to know and be sure that that child is in a specialized school. So I went there. This is my book. I have the book of the patient, because every child that has cancer has a book. And all the children, all the patients in Mbingo, they have a booklet with all the information. Usually for the children, we have pictures. So, and those pictures help us when we go back to the village, so that they will know, they know that truly that this is the true information, or is the right person that is in front of us. So when I discussed with the family, look at where this child is coming from. If this family was not supported, maybe this child would have been now in the grave. So I met the child. I cried when I saw this child. But the child is alive. The child is talking. She's speaking good French, and I evaluated the child. The work that was done was good, but this child needs what? This child needs prosthesis that the family have not thought that is still important. As this child is growing, if she does not have a prosthesis, it's going to deform her face. So we said that the battle of cancer is not over, even when the treatment is completed. Another patient, he came late, stage 4 Burkitt lymphoma, paraplegia, bed sore, urine incontinence. We finished by God's grace. He survived. They went to the village after the treatment. He is there in the house. Everybody's going to the farm. He cannot move. They sent this child to Sajuka, got rehabilitation, and this child with his equipment. So he was seen, I think, last 2 or 3 months ago, as we are doing the long-term survivorship. This is the patient in Jakiri, the survivor study. So we do also palliative care. We go to the house. So the palliative care, we have a palliative care nurse, a trained palliative care nurse. He goes to the village to see a patient that is on more on active treatment. If this child has enough morphine, what about the bed sore? How is happening with the family? Is the family coping? So it's encouraging the family. So this is when the palliative care nurse, behind this bag. Behind this bag, he has a box with morphine, with bonbon, so anyhow, he has some few things. So he has arrived in this house. He saw the child has a wheelchair, that's good. He's helping the family. This is morphine, so the child has to take morphine. So Joel goes to all the places except the places that are not dangerous, but he used to travel with the bike almost everywhere to go and give to make sure that the child has morphine. There's no side effect of morphine. And if there's side effect, what are they going to do? Is going to help the family on how to handle constipation and other side effects. We also do a lot of advocacy. It can be in the primary care, health care system, because those are the people that see patients at first, before they arrive Mbingo. Before a patient goes to Yaoundé, the patient is going to the nearest health center. Those are the people that need information. If they don't have the early warning sign, how are they going to send patients to Yaoundé or to Mbingo? So we go to the community also to teach them about early warning signs. I was talking about the parents' home. This is the parents' home where we have where patients stay there when they are in the hospital for their treatment. They don't need to go home as frequent. So what about the adult units? So when I came back in 2017, we started the adult unit. It is true that the adult unit started a bit before because we were having patients with Kaposi sarcoma. You have a patient with Kaposi sarcoma and HIV. The patient is taking the medication, the drug in Mbingo in the HIV center. You want to send the patient to Yaoundé to get the chemotherapy. So challenging, so difficult logistically. It is impossible. So we were giving some chemotherapy to those Kaposi sarcoma patients. But the real work started in 2017 when I returned. So we have averagely 7 new consultations per day and about 10 to 15 patients administered chemo on a daily basis. We have the Women's Health Program. We run the largest cervical prevention program in Cameroon. Between 2007 and 2014, the program screened about 50,000 women. These are the methods that we are using, the VIADC. These are some of the protocols that we are using. Now we are using high chop. We give, especially with the high dose methotrexate, that was challenging in the beginning. So we can, in Mbingo, we go to up to 8 grams per meter square without having how to measure the level of methotrexate. And I'm sure that my colleagues that are here maybe probably are going to ask questions. How are you using high dose methotrexate in such a hospital without having to measure the methotrexate level? But we are really succeeding by using those drugs. Continuous education for the nurses are really, really important. Formal certification, training in oncology nursing with the BBGH, training to nurses, new pediatric oncology. So we are training nurses so that they get a good learning curve. So we train the nurse, the entire nurse about staff and staff on chemotherapy, administration, and safety. And I think that I'm going to stop here, and maybe Dr. Aberi, if he's there, will continue to talk about chemotherapy safe administration. Over to you, Dr. Aberi. Dr. Aberi is a pharmacist, so he's going to talk here. We were not able to bring everybody, so Dr. Aberi will talk, and then Brian is going to talk about cancer registry.
Okay, Dr. Francine, thank you. Hello, Dr. Francine, please, can we just use your slide? Maybe you can just go to the next slide since the presentation is already on.
Wow, this was excellent. So Dr. Aberi, if you can also share your screen if that is possible. I made you a co-host, so.
Okay, that's fine.
Dr. Aberi, are you getting me?
Yes, Doc, I'm getting you. I was saying that since we had the presentation all on your slide, can we just use your presentation, or I go ahead and share my screen?
So, Aberic, the presentation is up. So if you want to continue, that's fine.
Okay,
you can tell her
okay.
which slides to go to.
Okay. Let me just get there. Okay, I think let her go to slide. Slide. Oh, the slides are not numbered. Let her just go to the next slide, please.
Yeah, so it looks like someone stopped sharing the slides, so
I better
you may
just share
have
your
to.
slides.
Okay.
While waiting on Dr. Aberi to set up, I think this has been one of the most touching presentations I've heard and seen, and we can now see how when I tell people, I think Mbingo has the most holistic and the most comprehensive management team of cancer that I've seen in Cameroon so far. And I think I am right about that, Elvis.
Very right, very right. And it gives me an impression. We've always known that cancer is a very, very difficult thing to manage, even for those who have the resources, even for the rich. But then I've never really imagined cancer among the poor, cancer among those in underserved communities. And this is the first time I'm coming face to face with someone who is dealing with this kind of a reality. It's another world on its own, Mona.
Yeah. So, Dr. Aberi, are you able to share?
Yes, that's fine. I'm on it now.
Okay.
Great.
Yeah, we are unable to see your slides. So
I think the first, I think
let me get the slide out of the way by doing that. I'm going to share mine and take off that, stop sharing. So that I can now take over this, I stop.
Okay.
Yeah.
Dr. Carter, this sounds like something more than diabetes. I know you're a diabetic expert. I'm sure you're like, this one is even more than me.
Elvis, I'm not limited to diabetes. I think you should know that.
I know, but I'm just saying, I'm talking about most of your work has been seeing those who are suffering with diabetes, but
yeah, of course.
It should be another world.
That's diabetes is one of the major players when we talk about NCDs, right?
Yeah.
Generally, when you mention NCDs, we think of the big five: cardiovascular diseases, diabetes, cancer, respiratory diseases, and of course, mental health disorders. So, Aberi,
that's
there
great.
You are.
Oh, great.
So there we are. That's excellent.
Okay, thank you so much. Alberic, a clinical pharmacist. I work with a team at Mbingo Baptist Hospital. So the role of the pharmacy in the multidisciplinary approach for the treatment of cancer cannot be overemphasized. We know once we navigate the patient and we have a diagnosis, from there we have to move on to treatment. And pharmacy plays quite of, they have a kind of multi-roles that they do play in the treatment. So the very first responsibility that we have is to ensure the safe compounding and the safe handling of these cytotoxics. As we already know, these drugs, they are hazardous in their nature, and they have very harmful effect even on those that are manipulating them. So at Mbingo Baptist Hospital, we have a compounding room where we do our chemo with a biosafety cabinet with that is designed with a biosafety type 2 cabinet that is designed for chemotherapy compounding. So all the preparations are done within this cabinet, and also we have infusion pumps which we use for the administration of these medicines. So while we are reconstituting the chemotherapy, we are also ensuring that limiting the exposure of the staffs that are working in this unit. So we have PPEs that for PPE, we mean personal protective equipment that are usually we put on both during administration and also during reconstitutions. So we have basically, there are 4 different routes of exposure which we can be exposed to this cytotoxic once we are manipulating them. We have the skin, we have the eye contact, we have inhalation, and also through the parenteral route. So our PPE are quite designed such that it minimizes exposure through these various routes. Also, most of our procedures in the compounding pharmacy section, we follow standard operating procedures. And most of the standard operating procedures that we use are from ISIOP. ISIOP is the International Society of Oncology Pharmacy Practitioners. So we have verified and referenced standard operating procedures that we use for chemotherapy reconstitution. Also, during the process of chemotherapy administration, we have waste that is being generated, both during the compounding. So also, we have to look for ways in which we manage this waste, because these wastes are also very toxic to the environment. So we have presently in Mbingo, we have an incinerator. Though the incinerator is a single chamber incinerator, but what we need for chemotherapy waste management, we need a double 2-chamber incinerator, which is recommended. And now on our plan on building the chemotherapy or the cancer center, there is a vision to include an incinerator that will be able to manage our waste, our cytotoxic waste, be it from the ward or from the compounding pharmacies. Also, there's this aspect of pharmacy which we call medication therapy management. As I earlier said, the pharmacy play a multi-role when it comes to the management of patients with cancer. We have the reconstitution aspect, and also we have the medication therapy management. Simply, we are trying to optimize the patient treatment when it comes to dose, to optimizing the dose, minimizing the toxicity, and also to reduce the severity of symptoms that may come as a result of these hazardous drugs that the patients are taking. Also, our team also help to optimize supportive care and adjuvant regimens. We also have to, we are also involved in palliation with these patients. Also, we do what we call medication reconciliation. It's worth noting that most of these patients, they have other chronic diseases like diabetes, hypertension, and other NCDs. So we are not managing their cancer in isolation. In most of the cases, the pharmacy has to do a kind of a medication reconciliation, that is kind of reconciling this patient on all the medications that they are taking, checking for possible drug interaction, possible toxicity, and also trying to optimize the patient and their outcomes. Not also limiting, we have some ongoing research at our facilities. We have the WIMS tumor Africa phase 2 research, which our major aim is to implement a protocol from the International Society of Oncology, of Pediatric Oncology, which is currently being implemented across 10 different cities in Africa. So I think Mbingo is part of the center that carries out these WIMS tumor phase 2 clinical trials. We also have a supportive care for children with cancer. That is, we are trying to reduce death during treatment to less than 10% by improving the nursing care and also the care on nutrition for this patient. We also have a study which is currently ongoing, which is aimed towards zero abandonment of treatment. So here we kind of try to one of the major causes why most of our patients, they kind of have abandonment from the past years. We saw that many of them, they have challenges accessing the hospital. You know, with them being on chemotherapy, they have to be there for a very long time. And so we definitely give them out-of-pocket money to ease their transportation to the hospital so as to reduce abandonment. Also, we have other trials that we are currently on rituximab, in the use of rituximab. That is, we are comparing the rituximab as standard dosing of 50 milligrams and 375 milligrams to our hyper-CVDA protocols, which we use for the treatment of Burkitt's lymphoma. And we have others too. So then we have a study that will be beginning in September, and it is a twinning study with between Cameroon and Kenya on an adapted early warning sign and symptom intervention to improve early recognition and diagnosis of childhood cancer, at finding the most effective way to deliver early diagnostic techniques and training so as to foster early referral, early detection and early referral of cancer. So here we have some of our studies from the past years that we have done, and with the results and follow-up plan. So we wish to acknowledge some of our partners that we have been working with. And I think by this, I come to the end of my presentation. I think I will now give over to Brian that will present to us on the cancer registry at Mbingo Baptist Hospital. Thank you.
Okay, thank you, Dr. Aberic. Please, can you just move your slides up so I should present from your slides, please, from your direction, please.
Okay. Brian, over to you.
Okay, all right, good. Good afternoon to the people in the diaspora, and good evening to those who are in Cameroon. I am Jato Brian. I am a nurse, and I'll be talking about the role of the nurse in the hospital-based cancer registry in helping cancer care. So as a vision, we want to make global available information on diagnosis, management, and long-term outcomes of all patients diagnosed with cancer in Cameroon. And our mission is to ensure that we generate valid information, reliable information to share with others in Cameroon to ensure correct data collection, data protection, and communication of data that will help in the management of patients with the diagnosis of cancer. When we look at the presentation Dr. Francine did, if we were not collecting appropriate data and ensuring that we have a multidisciplinary team, it will be difficult for us to be able to show proof that this treatment is helping the patients as well as it's not helping. So the role of the cancer registry is also very, very important. And so we want to ensure that we use standardized tools and reporting standard indicators with the support of the national, international partners and experts in cancer registration. Slide, please. Dr. Aberic, the next slide in Mbingo.
Yes, Ben, this is the next slide.
Precisely, in 2015, we had the setup of an electronic medical record system. And between 2015 to 2017, we used RECA to enter data for patients who were diagnosed with cancer. And in 2018, because we wanted to ensure data quality and we equally wanted to ensure that we are following the international standards, we had CanRec 5 software that was used with advice from the African Cancer Registry Network, so that we can be able to compare the data from different other countries with what we are doing in our own hospital. Slide. So the CBC Health Services Childhood Cancer Hospital-based Cancer Registry is an office that is responsible to collecting data, storage, analysis, interpretation of data on children diagnosed with cancer. I will be saying this and twinning it with that of the adults. So first, Mbingo Baptist Hospital is the main center for all of this, and we have satellite centers such as Banso Baptist Hospital, we have Baptist Hospital Mutengene, and then we have Mbopi Baptist Hospital in Douala. And we aim to estimate the burden of childhood cancers and plan care delivery. And it's with this estimate that you see how Dr. Francine goes out to do the follow-up for the patients based on the data we have collected from these satellite hospitals and comparing them to that with that of our main hospital. And so between 2003 to 2008, the patient information was stored on a protocol booklet and kept in a cabinet. And with the improvement of technology in between 2008 to 2015, we had a web-based electronic medical record system, PON, which was developed by St. Jude's Children Research Hospital in the USA. So we used PON over a period of time, and we had to switch in 2016 because of improvement in technology and data collection tools. We had to switch to Resonance, developed by a tech firm called Manu Solutions. And we are going to see the fields just gradually below as I move down. And so the PON-based Resonance was set up in 2016, and we capture information for all patients, be it children and adults. But PON was separate just for children. And so we try to capture the demographic data, the signs and symptoms, diagnosis, management, and prognosis. And so this patient information was stored and managed in a secure environment. So we have a web base where this information is being stored. So this is a picture of the Resonance software that we're using. So you have your username. For everybody who has to use it, you have a username and a password that gives you access to it so that the data is being protected. Slide, please. Just move down. Next slide, please, Dr. Aberic. So we want to look at, this is how the Resonance page appears. And so all other hospitals who are involved in this have their informations put up here. So once you log into the system, you can see the information from Mbopi Baptist Hospital, as well as you could also see information of patients entered at Baptist Hospital Mutengene, as well as you can see patients entered at Banso Baptist Hospital. So with the help of the African Cancer Registry Network and a means of seeing how we can collect data for adults, we moved to CanRec 5. Dr. Aberic, can you just go down and project the screen for CanRec 5? So CanRec 5 is the data collection tool that was set up by IAC, and CanRec 5 is used to compare information from different countries. So we have specific fields that can be collected and you can compare the data. And so this is our data abstraction form. And slide, please. So on this data abstraction form, you want to check on the primary side of the tumor, the morphology, the laterality, and the clinical staging, as well as the TNM staging. And then we want to see, did these patients have surgery? Did they have hormonal therapy? Did they receive radiology? Did they receive chemotherapy or immunotherapy? And some people come to the hospital when they have received alternative medicine, that's traditional medicine. So we also want to capture this data. And we also want to get the source, which institution is this patient coming from? Sometimes we have patients who come to Mbingo who are already diagnosed in another hospital. So we also need to include where they are coming from, and we do the follow-up. Dr. Abrig, please, you can just move down. Next slide. Next slide. So who are those involved in the cancer registry or hospital-based cancer registry of Mbingo Baptist Hospital? So we have core members, which is made of the oncologists. We have assigned medical doctors, nurse practitioners. We have pediatric oncology nurses, as well as adult oncology nurses. We have the pathologists. We have a pediatric surgeon. We have the ophthalmologist. I think we're missing out the ENT specialists too here. And then we have the registrar, and then we have other members of the team, such as the sonographers, the laboratory scientists, the nutritionists, and other consultants. Next slide. So who is involved? So we, as a team, we train our own staff to collect good quality data for cancer registry. And so it is always important that we use nurses who also have a background information on science, so they can be able to give us good quality data. And so the core members have the responsibility to complete the patient protocol booklet on a day-to-day patient contact, so that when you are capturing this information, even though the burden of work is too much, I really want to appreciate Dr. Francine and the rest of the team. They try as much as possible to give you all the data you will need to upload on the system. And the registrar uploads this, and then sometimes the registrar travels to the different centers every 2 months to ensure how data is collected and to ensure that the data is up to date. And we have a dedicated laptop and a modem for data source, because Resonance uses internet, the same as CanReg. So sometimes you need good internet to ensure that you enter the data. Next slide. So who are our collaborators? So we have our current collaborators. We have the African Cancer Registry Network. We have Watch Eye Cancer. We have St. Jude's Research Hospital. And our potential collaborators, we are looking at the International Agency for Research on Cancer, IAC, Clinton Health Access Initiative, the National Committee for Fight Against Cancer, University of Alabama, and then we have Bao Ventures for Global Health. In data collection, Dr. Abrig, the next slide. So what are the challenges we experience when we are entering this data? We have challenges because you will not be able to put up a form with all the patient's information. And so we have little dedicated time for data manager, insufficient training or reporting for general hospital staffs, and we have challenging to obtain long-term follow-up data. Next challenges we have. So in my conclusion, I'll be saying that the hospital-based cancer registry is an important resource for population-based cancer registries. In Cameroon, we had just one population-based cancer registry that existed in Yaoundé. And so we are hoping that with the collection of this data from our own hospital-based cancer registry, other hospitals who will buy this, and gradually we can have an up-to-date incidence on cancer diagnosis in Cameroon. And so we are also saying that we need to dedicate resources that are required to transition from a hospital-based cancer registry to a population-based cancer registry. Thank you very much. That's the end of my presentation. Thanks.
Thank you, Mr. Jato. We are going to hand over. The last few slides will be the radiologist, Dr. Fejo. Over to you, Dr. Fejo.
Thank you, Dr. Francine, for giving me the floor. I'm Dr. Fujus Lang. I'm a radiologist based in Mbingo Baptist Hospital. As we are discussing about cancer in Cameroon, you should know that most of our patients usually come late. So our time is challenging. And with the advent of CT scan in Mbingo, has really helped us for the staging of our patient. But most of the time, the clinician want us instead to help them to get the primary, because you know some tumors are not accessible for easy tissue sampling. So at times they want the CT scan to give them the primary tumor instead of doing the staging. And some of our patients don't usually have staging as you're supposed to have. Let me take the example of breast cancer and cervical cancer. We are supposed to do a thoracoid, we need pelican, CT scan, but sometimes patients don't have finances. So you have to do chest X-ray and abdominal ultrasound. I know you can miss some masses in the lung mostly if you have small nodule. So even though I've asked patients to get the thoracoid, the pelvic scan, that can cost in our place around 100,000, even though it's cheap, but some patients cannot access it. So the oncology has to do with the finances of the patient, knowing that after you may get some vision while you are restaging. So one of the challenges is that some tumor, like in the lung, the retroperitoneum, the kidney, at times it's difficult to get access. So they rely on the hypothesis from the imaging, or we need to do some imaging guided procedure that we are not quite versed. We are trying with some lung tumor, but other tumor, surgeon can help us to get the tumor, but at times it's challenging, because the pathology is there ready on site waiting for the specimen, but to get the specimen also at times is challenging. So imaging tries best to reduce the diagnosis, but we need get some skill on imaging guided procedure to get those retroperitoneum, kidney, spinal, or lung. Most of the lung matter are central. At times we can get through bronchoscopy, but at times it's challenged. So at least imaging has really helped our patient to get the staging, and to those who can afford. Some patients, you know, that they cannot see maybe the primary, they may need PET scan, but that one is not on our scope. So we are trying to do what we have. And what we also have, when we are doing our multidisciplinary team meeting with our friend in other country, like in Leeds, we do teleradiology. So we send them the image so that they can see our approach. They can advise maybe how to do for the nephrectomy. So you have surgeons, you have other radiologists that help us in those challenging cases for the management. So that high imaging is helping in the multidisciplinary team to help the approach for the staging. I also help to get some time the possible primary. Thank you.
Okay, thank you. So I just want to round up and appreciate all my colleagues in Mbingo, all the surgeons, all the nurses, and even the patient in a time like this in Cameroon, where sometimes the patient have to brave the odds, stray bullets, the blockage of the road, and they still manage to come to Mbingo so that we take care of them. We also want to appreciate the diaspora and everyone who made his own time to come and listen to what is possible in Cameroon. Thank you so much.
Thank you so much, Dr. Francine, Kouya, and your team. I think we've just had a very, very intriguing set of presentation this evening. It's been multidisciplinary, really showing the team effort that is required for anything to be efficient, especially when it concerns cancer care. So we've had presentations from you, Dr. Francine, Kouya, from Aberic, from Brian, and from Ghislaine, just really showing that teamwork is very, very important. But so we are going to proceed to a series of questions and answers. But before we do that, probably I'm going to ask the team to kindly put down the slides or stop sharing so that we can have a good view of the screen. I'm gladly going to ask a couple of people who are with us today just to get their first impressions from the presentations while we prepare for answers, for questions and answers. I'm going to start with Dr. Valentine Kouya. I don't know if he's there.
Hi, can you hear me?
Yes, we can hear you fine.
Yes. Thank you so much for asking me for my opinion. And I would just want to thank the team in Mbingo. My normal self is to be critical about something, but my God, listening to them speak, you cannot just be but amazed at the kind of work that they are doing back in Cameroon. It pleases me to see every member of the team coming up and speaking the kind of a language that I like to hear, how people are collaborating to bring cancer care to our people. And it's no doubt, definitely, that in a country like ours where it's user pay and people have to pay for their own scans and their own treatment, it's a very difficult feat to provide this kind of high quality treatment. This opens the room, therefore, for those of us in the diaspora to see how we can work together and collaborate with teams like this to support the kind of work that they are doing back on the ground. I will have no question to them because I'm just so pleased and excited for what they are doing. Thank you so much for presenting this to us today.
Thank you very much, Dr. Kouya. I'm going to spin over to the other side of the Atlantic and ask Dr. Ivo Dita. I don't know if he's still connected.
Yes, I'm right here, sir.
All right.
You know, in the same light, like the previous speaker, I really want to use this opportunity to thank the team in Mbingo. It is really heartwarming to see the work you guys are doing. You know, sometimes it's easy for those of us who are in the diaspora to be armchair critics. We are not there to do the work, but based on what I saw here today, I am so reassured of the great work you guys are doing. We can only encourage you and say, please, those of us who are in the diaspora, how can we help? How can we collaborate? How can we work together? How can we bring our expertise, any resources that we have here to bear and improve the quality of the work that you guys are already doing? Please do not get discouraged. You will have folks yelling at you and telling you you don't know what you're doing, despite all the good work with so much limited resources, trekking to people's homes, chasing down children and trying to see how you can get them the best. It's not given to everyone. Kudos to your team. And I'll tell you what, I will be reaching out to Dr. Francine and her team after this to see how we can help support and work with you guys back home as we sit in our comfortable seats, chairs out here in the diaspora, and only know how to criticize. So thank you so much, and I look forward to the answer, to the question and answer session. Thank you.
Thank you very much, Dr. Dita. Just to mention that if you've got questions, you can kindly just raise your hand. We're going to get to those questions in a second. I also want to hear from Dr. Sydney, who I know is doing some good work around medical radiology, if I'm correct. Just to get some of your thoughts, Sydney. I don't know how good. Yeah, I can see you. Great.
Yes, thanks, Dr. Kate. Thank you for this wonderful team that you guys have brought to the town hall this afternoon. I am very, very happy to be part of the the group of people who are working every day in the USA, in Cameroon, and Mbingo, at all the hospitals in Douala and Yaoundé to bring cancer care in Cameroon, despite the limited resources that we have. With what Mbingo is doing, I work under the belief that let's not let perfection be an enemy to good. And sometimes we have very limited resources, and we just have to do the best that we can, knowing that, like she started on our very first talk about the patients who, although they ended up dying, but they were able to make a significant difference in the patient's life. And I think that's what makes us go home every night and be able to sleep, knowing that what we're doing is making a difference. So I do have quite a few questions, but I'll save those for later. Thank you, guys, and I look forward to the rest of this session.
Thank you very much, Sydney. We can call everyone up, but I think I'll call one last person. I'll put Carlson on the spot. Carlson Matthias, if you're there, can you hear me?
Yes, good evening to everyone in the house, and thanks very much to Dr. Francine for the presentation. And I can say it's very heartwarming to finally, as for me, I've been working the Yaoundé medical oncology unit. It's so much of a pleasure for me to see a face behind the letters and the correspondence we had. At times they sent patients to us in Yaoundé, and also we also wrote back to them with a team of now Professor Nom, also Professor Atemlina in Yaoundé. And what I must say is I like the approach, which is a holistic approach, where you have all of the teams coming in to manage the patient. And as mentioned earlier, there are so many challenges, even for us in the referral hospital, which was the biggest center in Cameroon, in Yaoundé. We still had challenges like in the management of our patients. We never had radiotherapy. We had to start treating patients, and you'd send them to Douala for radiotherapy, and some get lost, and patients are coming to us from various parts of the country. And I still think Mbingo is doing an amazing job. What we need is more collaboration, and we need the government to actually invest, or even private investors to have some of these services provided in one place, because a patient coming for cancer has already traveled the whole country, and he comes to Yaoundé, you treat him and you tell him, please go to Douala for radiotherapy. And after 1 month, come to Yaoundé. He has no family in Douala. He has no family in this other place. These are some of the challenges that patients face on a daily basis. And at times I told myself, I'm prescribing drugs for patients, which I can't buy I can't be able to purchase them if I had a cancer. But these are some of the realities which are on the ground, but kudos to the team. And I think we can actually move forward.
Thank you so much, Carlson. And I think what more can we say, actually, Muno? So over to you. So before I'm still waiting for hands, actually. So
yeah. Well, so Kathy, I would want to say one thing. After listening to the Mbingo team, it's a team I kind of know a little bit about. I could feel how holistic their approach is, how humanitarian this approach they're using to treat cancer, where every member of the team forms a pillar as being part of that team. I know there are a lot of questions people ask, where is money coming from in order to take care of these patients? But what they're doing is phenomenal, because we cannot keep ourselves, especially us in the diaspora, we're good at criticizing at times without even proposing solutions. We are good at playing the victim game and actually not wanting to go and put our foot in the soil and dirty our foot. So I think that it's time for us in the diaspora to appreciate teams like this, be able to help them, especially those who are in healthcare, be able to go there and volunteer, be able to advocate for financial resources so that we can actually get radiation therapy available at Mbingo. I think that should be one of the advocacies that this should go forward for us, and also access to latest medication. So I'm not going to really ask questions to Dr. Francine. I'm going to just give a heartwarming encouragement to what she is doing so far. And I think what they're doing is something that everyone else needs to emulate. And even the cancer centers in Yaoundé, which I know very well, I'm sorry to say certain things at times, their approach they need to learn to have the holistic approach that Mbingo has, the human touch when it comes to cancer treatment, which you cannot treat cancer as an oncologist alone without training nurses, without training pharmacists, without having palliative care involved, without even having access to morphine, which Mbingo has all of that, without having access to nurse navigators who are going to navigate the system. You need a survivorship program to be able to follow up these patients. I was almost moved to tears. And the good thing about her presentation was we got to see the reality of cancers, those who got well, those who we help palliate them over time, those who had additional years to be able to do what they could do, those who help even reduce the burden on the patients and their families about what psychological impact, and also in our culture where there's a lot of thought about witchcraft. So it's amazing what they're doing, Dr. Kate. So let me not take all the time. We need time for questions and reflections and answers, not only questions, but contributions also. So over to you, moderator.
Thank you so much, Chair. I was just about to add that we really need contributions, comments. But we have Asangazi who's got the hand up. So over to you. You can just unmute and try and be brief so that we use the remaining 40 minutes or so judiciously.
Thank you very much for offering me the floor. It's an honor once more to talk here. I am a medical doctor, general practitioner. I work at MAMFI, and I have two things to say. The first thing is I just want to add my voice to thank you to the team. I don't want to crash. Secondly, I want to say that I think that at times we can underestimate the power that this town hall can have. I feel that this is a powerful tool we can use to do something in respect to cancer in Cameroon. We know that from time to time we do have a Minister of Public Health here. In Cameroon, certain diseases are being the government helps, like in HIV, the treatment is free of charge, in tuberculosis, and I just want to say that I think that cancer should be part and parcel of the diseases that the government should handle. Because, truth be told, there is no family, or there are very, very few families that in Cameroon can pay for cancer treatment. So I think that this town hall can, first of all, unanimously agree on that. Then we can do something. We can write to the ministry. We can write a letter to the minister to tell him that we have a lot of patients with cancer and they cannot even afford some of these things. Maybe the government should think of what to do to save the life of its citizens who have cancer. I will share this personal story. I recently received a 10-year-old girl. She came to the hospital, hepatosplenomegaly, she had fever. In doing a full blood count, I noticed that she had a leukocytosis of over 78,000. Very dark, beautiful girl. Still about 10 years. To cut the long story short, this girl had to die in like a month's time. I had to refer them to see a hematologist, and the next thing I learned was that she died. Those are the type of stories we have here, because the people don't have money, or we don't have some of these services. So I think that what we can do as a town hall, first we can write to make the minister know that this is something, if they can do for HIV, they can do for tuberculosis issue, they can do something for cancer, they can do something. And also, I still want to say that those who are out there, if there are drugs that people can send for us, whether it's methotrexate, something that we can use here in our country, even to help if there are equipment, it will be of great importance. He spoke of volunteering. We will be so happy to have people around, even to come and teach in med schools and all those people will be so happy, even during your holidays. Thank you very much.
Thank you very much, Asangazi. That was very useful. Those were useful comments. I don't know if Elvis wants to react to that, our policy analyst and advocate by excellence.
Yes, I would, Kate, I would want to say something to say that. Thank you for just acknowledging the fact that the town hall has this a tremendous impact on the healthcare system back home, that we can speak now and at least some voices will listen. First, we have a committee that has been set up by the minister in charge of diaspora health. And this committee is very powerful in just channeling information that can be helpful for the ministry. And we have members of that committee in the town hall today. We have Dr. Samuel, who is here, and they have had their second meeting. And I think they're working very hard just to carry on very important ideas like this to bring it on top of the agenda of the Ministry of Public Health. And so I think we have a very important platform, and it's all because of you. It's not because of any individual. It's because of all of you who come here every 2 weeks to sit and have this very important conversation. As we continue to increase our reach, we were 1,820. And last time, Muno looked at the statistics on our back end and told me we are now at 2,000, about 2,100 participants of the town hall from more than 36 countries now. So it's because of all of you that we have that power to make our voices heard by the Ministry of Health. And we have a minister who is also giving us his ears and taking our words serious, and our advocacy also very serious. So we'll continue to make this advocacy about cancer as well. But one of the things I think, if you permit me, Kate, to just use this opportunity to speak about is that I was very interested. It was very interesting to see that Mbingo has this collaboration with the St. Jude's Cancer Children Hospital. But when I watched CNN here, I can't tell you how many times I've donated to St. Jude Children's Hospital because of the kind of captivating art that they pass on CNN, just telling you the stories. It's all about storytelling of how children have come to benefit from their services without even paying for lodging, without paying for transport or anything. And you hear those testimonies from those parents and you are really, 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 really convinced to donate. So I'm just trying to ask the laws in Cameroon. I know that there are laws that prohibit people from doing public fundraising on media. But I don't know if this amazing work you are doing, you can have the power from the Ministry of Territorial Administration to do public fundraising for this amazing work. In that case, then I can assure you that some of us out here will be able to pay for your media fee, to cover your media fee on CRTV, on all the channel. Just a little like 30 seconds ad on CRTV with some stories, heartwarming stories like the one you've shown us, that is appealing for people to donate, to take care of some of those indirect costs that comes to caring for these children with cancer. That would be a tremendous way of fundraising, because one of the reasons you even will lack funds is because people don't even know what you're doing. Very few people will hear this for the first time of what you're doing. But imagine if you have an ad that passes on CRTV or maybe Equinox or any of your local channel there that just tell the story of what you are doing and ask people to donate on mobile money on everything. You will find tremendous inflow of money that is coming from really, really people who care about work like this. And I think if it's an idea, if you pursue and you think that the town hall can help in any way, we'll be very glad even to cover your media fee for the first couple of months.
Thank you. I think Dr. Kouya's hand is up, maybe to respond to Asangazi and to what Elvis just said.
Yeah. Okay. So thank you. Let me just go ahead. So for the fundraising, we are also working with St. Jude's so that they should train, because they have the skill, they have been able to do fundraising. So we already have a committee for the fundraising. So we are in the process to see how they are going to support us so that we move with the fundraising. That is the one thing that I want to say. And the second thing, I think Dr. Ngok, the pediatric surgeon, I've worked with Dr. Ngok, the Wim Streamer protocol project. He has been so useful. The child that I showed you, that's when he came with that massive tumor, is Dr. Ngok. We look at the child and say that this child is too sick. Dr. Ngok said bravely, let me do the procedure. Let me take the biopsy and do the electrostomy. So that was so brave, and I've enjoyed working with him. So I would have loved him even to say something for 5 minutes. Yeah, I think he's still there about how he's doing surgery in this difficult condition, malnutrition, no money. So it's very challenging, but I admire his courage, and his courage has also empowered the whole team to move forward. So, Dr. Ngok?
Yes. Hello.
Yeah, so it's my duty to present Dr. Ngok. He's a pediatric surgeon. Truly, it is an honor for me to see you here, and I want you to say something.
Okay, can I go ahead?
Yes.
Please.
Yeah, I want to thank everybody for this opportunity. And I'm also very thankful to my brothers and sisters in the diaspora who today have taken the time to listen to us and what we're doing here in Mbingo. Yeah, as Francine has said, well, I don't want to blush, but look as if my reputation precedes me. But I think we work as a team, and I really enjoy working with the team. It's been very challenging since I came back to Mbingo here in 2017 after finishing my fellowship in Kenya. In real practice, actually, you meet these children who need surgery. They don't have money. They are really sick, advanced disease. But we, as a team that I enjoy working with very much, we have been able to scale through. Because the biggest problem we have come to have here actually is finances. Because imagine that it's true that the drugs are provided. Surgery too, we have been able to get some funds, like Dr. Francine had mentioned before, to help these patients get their surgery done. Because sometimes, especially the women I would speak for in particular, who get their chemotherapy, and they cannot have, since we're using the SIRE protocol here in Mbingo, and they cannot have the surgery done, and I just defeated the whole effort, effort I started at the beginning, because they need to get their chemotherapy and surgery on a timely basis. If you miss the time, then you don't get that patient cured. But I want to just say that despite the challenges, we still get high cure rates in these patients. The statistics will show you if you care to check. And like the last speakers have mentioned, I think when I go looking forward, I think the main problem for me now is that of sustainability, whatever we're doing in Mbingo, because no matter how we calculate the good work we have done is true, and we appreciate people appreciating us for doing those good work. But I think if we don't sustain what we are doing in Mbingo, not only in Mbingo, in the whole of the country, hopefully that should spread the good news. If we don't sustain what we are doing, then it's a waste of time. In terms of funding for chemotherapy, radiotherapy, and surgery. Because I, for one, I'm of the belief not only for cancer patient babies and children. Sorry, I speak particularly of my children. Any child that gets to Mbingo here and that needs surgery, I, for one, whether the money is there or not, I don't refuse that child's surgery. Yes, and I try to make sure that is extended to all my cancer patients as much as I can. So, but again, I still go back to sustainability. So I think one of my suggestions before I conclude is that one way that I think diaspora can really help us is how we can sustain this program, whether it is cancer-wise or any other aspects of the healthcare system in Cameroon that we can sustain. We need to think about sustainability. And like Elvis was saying, we don't know. Honestly, I'm not versed with the laws in Cameroon on fundraising. But like, for example, I'm just thinking out loud. What are people like Brazzaville doing about MTN, Orange, those big companies in Cameroon? So I don't know. I mean, this was one of my thoughts I was also sharing with my good friend, Dr. Glenn. Yes, Mark Glenn. So these are the things that we need to think about as we move forward. And with the power bestowed on the town hall, we hope that we can look into these areas. Sustainability. Thank you very much.
Thank you so much, Dr. Gok. I don't know, I think I would go to George, whose hand has been up for a question before I go to you, Mona. That's okay.
Thank you very much, Dr. Kati. Actually, it's more of testimony than a question. I'm George. I'm actually based in Houston, but I worked in BBH, Council Baptist Hospital, from 2014 to 2015, and I had the privilege of briefly meeting Dr. Ngok before he went for his fellowship in Kenya, and had some interactions with Dr. Francine, because I was mostly working with HIV patients and some with malignancies. I had to interact with her either to refer them to Mbingo, or she sent some follow-up to BBH. So it's a pleasure and honor to tie a face to the voice I had been talking with. Secondly, I also worked with Dr. Kifem, who I'm happy to hear is now in India, and Dr. Glenn, who then was just Glenn as a nurse, and they were actually coordinating what was called the Burkitt's ward in BBH, which took care of these children. The point I would like to bring out today, which was mentioned by Brian and a little by Dr. Mono, is like the social aspect or the social impact that this work has. From my little time in BBH, what I noticed was that the work they are doing, this multidisciplinary work, had a certain impact on what I would call demystifying certain taboos. What do I mean? If we look at all these pediatric cancers, they have a very dramatic, very traumatic physical appearance. They are really scary. And most of the time, they always have a mystical connotation. And so in the course of this management, it was possible to make these people, the parents, the family, understand that this is not uncle or auntie or village curse or family curse, but that it was a disease and it could be managed. The second aspect, social aspect, that I noticed when I was interacting with Dr. Kifem then was that some of these people whose children were treated went back into the community, and sometimes they would notice a friend or a relative or a quarter neighbor whose child looks like their child. They would tell them, my uncle is picking me this, so they be carry go Mbingo. So that social positive kind of congosa created an impact, and you'd receive a client with a child, and she would tell you that my auntie is picking me this, so they be saying, I come for a year. So I think the aspect of demystifying some of these cultural taboos, of giving the impression that most of the time these weird appearances in children have some mystical origins, is very important, because now it makes people have a more objective way of looking at these things and probably getting more, coming more to the hospital. I just want to end by continuing to appreciate the work they are doing. Thank you, and over.
Thank you so much, George. You raised the issue of positive gossip. I think that's something that we would probably look into as a case study for other diseases. Mona, up to you.
I don't know if Dr. Francine and her team had any reaction before I talk, Kate.
Okay.
Any reactions? If not, well, yeah.
Okay, so I don't know if my other colleague want to talk, but what I want to say is that when we started the work in Mbingo, in the CBC, we didn't have WhatsApp. We didn't have what we have today. As my colleague, one of the colleagues has just spoke now. You know, it was from the parents became advocates. Parents were writing our name in a small piece of paper and say, you know, I saw this child in the village. And he also did that Dr. Baglen and the team, they went to the children and said, please, if you have a child like this, but don't do scarification. And
we're having a little network issue with Dr. Francine. Dr. Francine, we're having difficulties getting you very well. We are having some little difficulties.
I think I would.
Yeah.
And I am telling you that what happened.
Mona, can you mute from your end, and then we would probably get to her later.
Maybe I should just go ahead on the other computer.
Yes, we're having difficulties hearing you, please. And you were saying something important, so.
So I just said that really the community matter a lot. So when we started this treatment in Mbingo, what happens that the parents became advocates because we are working with the early warning signs. So we have those, how they call it, the leaflets, and those parents are going out. Some of the parents, in 80% of the case, they went back to the community. And anytime that the child has maybe a tumor or a deformity, they will send us a picture and say that, okay, send the child back to Mbingo. And usually it was a malignancy. And another thing that we also did is to work with a traditional healer. Because we noticed that some of the children with their tumor, they went to see the traditional healer, they did scarification, and the children were having severe bleeding. So they carried out a study, they went out, discussed with them and told them what they are supposed to do. And that study, it really went well because around 90% of the children with tumor were referred by the traditional healer, and 80%, around 80%, they were true. It was true that it was malignancy. So than to fight with people, fight with the diaspora fighting with us, we're fighting with the traditional healer. We can work together and improve the care of the children. Not the children and also the adults.
Yeah, thank you.
Okay, so I have a question for the Mbingo team and Dr. Francine. If you have to prioritize, what are your needs when it comes to the diaspora? What are the things that will be able, I know finance is going to be one. Mbingo is a big organization, yes, but what are your needs when it comes to, if you're dealing with the human resource back in the diaspora, and you say, okay, you will need certain help in order to improve the care of your patients, or to be able to help certain patients who cannot afford care. Do you have a priority list where you can be able to let us know? Because I don't want to I've just been thinking about something, maybe because I deal with cancer, and I think that it's one of those things that you can easily fundraise for particular situations. So my real question is it going to be human resource helping? Is it going to be a financial help? Is it going to be volunteering? Is it equipment? What are the kind of things that the diaspora can advocate for Mbingo?
Okay, thank you. I think I will speak, and I think Dr. Ngok and the other colleague will also add. Presently, we are building a bunker because, you know, the situation, you are living in the Northwest, you are coming maybe from Kambi, and you are coming for Mbingo, you receive your chemotherapy, then they ask you go to Douala for radiotherapy. It's never going to happen. Some of the patients told me, doctor, you know, I've never been to Bamenda. As a Cameroonian, this is something that we see every day. So with these challenges, so we started thinking, no, we need something. And then also we started thinking about putting a radiotherapy center in Mbingo. So they are building now the bunker. The bunker is under construction. So those are the things that we are thinking. And yeah, it is a huge project. We need a lot of money. So yeah, we need to also we need to train a second biologist. We need medication. but I, in my heart, that if you have really, it is the best.
Kathy, we are losing Dr. Francine again. If she can go back to the computer where she was, that would be good.
The network is becoming
because
bad.
that the drug costs family to send their
Yeah, we understand the network back home at times can be very troubling. So I think from what Dr. Francine just said, Sydney, you are in a big position, your hand is up. You're in a big position, not because you're the president of MedRat, also Africa. And I don't want to put you on the spotlight.
You can't hear.
So you're the president of MedRat Africa and newly elected. And just for us seeing what they're doing, I think the cry from Mbingo is really the radiation department needs help. The radiation oncology department needs help. And you being a seasoned physicist who understands this part of that, I think we need to, you're always in Cameroon, we need to evaluate their needs and see how we cannot buy those things, but we can advocate for them. And we can advocate for an association as big as Mbingo to see. I know you guys have done, MedRat has done a lot of work in Mbingo that I know, and in the past with Dr. Foyong and others, but I would want you to add to this. My other really worry too always comes with, I always discuss this with Dr. Francine, how can we reinforce their pathology department, especially that we do not get to do histochemistry out of Bamenda, only in Central Pasteur, where we can be able to get certain things. That I think that's one other part that I think is going to help a lot. So I know we're getting from Dr. Francine and her network was a bit a problem. So Sydney, Kathy, I'm sorry, let me get over. I wanted to put Sydney on the spotlight, please. His hand was up after me.
Yeah.
I want to hear from him what he can do.
Yeah, Muno, yes. Yeah, thanks for bringing that up. So yeah, I am currently the program director for RAD8 Cameroon, and actually 2 months ago I actually tried to make a trip out to Mbingo. Mbingo is one of our key pioneer sites, and I've had the privilege to be in quite a few meetings with Murphy Cancer Center, which is the second largest cancer treatment center in the U.S., and they have expressed a willingness and the ability to help. So having a partner like that behind, obviously we're still in the very early stages, but the work that Mbingo is doing, like you guys have seen, is really amazing. So Murphy Cancer Center has expressed interest to help Mbingo. I've had meetings with Dr. Palmer, who is the CEO of Mbingo, based in the US and obviously in Bamenda. And yes, we have a lot of things that we're working on. Now, specifically, one item of that I think can be of one item that will be particular interest is in training, right? So in addition to what RAD8 can do for Mbingo, my organization itself is also able to provide and assist training both the technologists, but also the radiographers and the physicists and even the doctors. So Dr. Francine might not know me. I definitely, obviously, I'm hoping that I'm planning. I know we're gonna get to know each other very, very closely. But I currently am working in the background to do a lot of things, both in Mbingo, and this information is not just from Mbingo, right? For all the medical professionals out here, please reach out to me. RAD8 is based in the USA. They have a lot of money, a ton of money, and they are willing to help, and they are able to help. IT, training, equipment, and of course, on-site support. So my contact is on the, I'll put my contact out there. You can reach out to me, but Mbingo for sure. I'm very, very optimistic over the kind of work that we're going to do together with Mbingo, both as an individual, but also as a president of Ride It Cameroon.
Thank you so much, Sydney. I think that was just a smooth transition, right, from what Francine and Mona they were saying to what you were bringing in through that organization and also your partners. And yep, we are going slowly to the second hour mark, but we have Kwan Jacob, probably for questions or comments.
Yeah, thank you, sir. As you mentioned, I'm Kwan Jacob. I'm a nurse working with the Cameroon Baptist Convention. I happen to be very close to Mbingo, and I have some bit of ideas about some of the needs. I'm sure Dr. Francine would have mentioned if she really continued to the end, if the network did not interrupt her. Majority of these children are coming from very poor backgrounds. Sometimes the first thing, they don't even have transport to come to the hospital. And then those that manage to come, sometimes they don't even have food. Some of them, they don't have even a caregiver that will volunteer to stay with the children. And some of them are orphans. I mean, the social needs are also there. And I think that if we have organizations that can also be willing to maybe focus on the social needs, I think this will also help many of them to be able to come to the hospital, to also have food during their stay in the hospital. Thank you.
Thank you very much. I don't know if anybody from the team in Mbingo, if they want to respond to that briefly before we go to Asongazi.
Yeah. So I think Jacob works with Mbingo, so his needs, that's very important. We have taken down some of the needs. The reason I asked that question is because setting priorities, I think I'll get back to Dr. Francine after this, is very important for us to be able to, Mbingo is a mission-based hospital, an organization, and it's easy to crowd fund, to actually galvanize funding for them and be something we can really do easily. But Kate, over to you for the next question.
Thank you. I mean, we are aware of some of the really big projects that the CBC Health Services are undertaking in Cameroon in other areas of health. So probably they, one way or the other, I'm sure they've got really some good experience raising funds. So probably just targeting cancer might be something to add into their basket. Asongazi, a quick one from you, maybe. Asongazi, can you hear us? Are you there? Okay, maybe that's a legacy hand. I think before we end or go towards, since we are going towards the end, yes, Ghislaine, please.
Okay, thank you for giving back the floor.
Yeah.
As advocacy in the imaging department, we are thinking how to get some help, maybe some volunteer in basic interventional radiology. As I was saying, some image, some tissue sampling are quite challenging to get. We have a CT scan, but we cannot really say we can do well. Some lung biopsy, some retroperitoneal biopsy. So if there are people that can help in hand-on skill to come, and we have been working with on Ride It. I'm happy that with Sydney doesn't talk about it because I work in the past with Dr. Forion. He has been busy. So if we have some hand-on, even by Zoom, but it's good to be on the field to help to go to some of those organs, some of those masses that are quite challenging to get. So that's why I can sound imaging. And you have teleradiology, even some challenging cases. You have some radiologists abroad. You have some, but it's always good to have additional, mostly on specific area, like maybe neuroradiology or chest cardiovascular. There's one specific area that are quite challenging. But in Cameroon, we do the general radiology. Some of those specialties are quite challenging. So that's what I can say about imaging. Thank you.
Thank you so much, Ghislaine. I think we've had a quite intriguing presentation and discussion, actually stimulating all sorts of hormones in our bodies, oxytocin and all other emotional hormones that we know about. So, but I would like to call Dr. Samuel for any thoughts on what we've discussed and shared so far.
Thank you, Dr. Kate. I'm sorry, I think I joined halfway in the presentation. And really, this was kudos to the whole team. As everyone has said, teamwork is really key. And having them also demonstrating that even though there is no national registry, the hospital-based registry, as I said in on the post there, is going to probably pave the way for us as we work together to have a national registry. And to add to what Elvis was saying, I want to add that the town hall is doing a wonderful work. As Elvis said, we've been working on a workshop, and I think in the near future, all this work and the challenges that we're having in order to really showcase our success story, which what Mbingo is doing, will be something good. The Ministry of Public Health is trying to have a platform where we will be able to share all the wonderful work that is being done, able to reach out. I think one of Dr. Mono's question was to know specific need. Yeah, the needs can be many, but at times there might be some pressing one that we can easily see how we can help. And also to Elvis' point, sometimes if Mbingo or other groups, they could have a way that they can raise funds through our own media platform back in Cameroon. Many of us can donate. So those are things to look at. But with this new platform, working with the Ministry of Public Health, I think with time, it's going to be something that will be very helpful. And this is thanks to the town hall. So there are a lot in the pipeline coming up, which we're very excited. And all the success stories, all this discussion that we're having, we'll be able to have it in one spot, and where we can just say, go to this particular platform, share your story, share your ideas. If you have suggestions or you're coming from diaspora to do something back in Cameroon, you will be able to have that access. So this was really interesting, and I want to appreciate the team for putting a wonderful presentation, especially the work they're doing on the ground. If you are not really on the ground, you will not understand the challenges they are going through. So I really, this was really a great work they're doing. And back to Dr. Ngok, sustainability is really key. At the end of the day, if the program is not sustainable, it's all the research will basically go in vain. So it is something for us to look at. Thank you, Dr. Kate.
Thank you very much, Dr. Samuel. I think with the call from the town hall, Sydney, we would probably extend maybe for another 10 minutes or so, just to really get some closing remarks from some of the members on the town hall and the moderators. And I can see Sydney's hand is up as well. But before I get to you, Sydney, I don't know if we can get any remarks from Professor Weleji, who is attending. I think he's been listening right from the start of the presentations. I don't know if Prof is there. If not, I would pick on Dr. Brice Nute.
Hello, dear all.
Great.
Sorry, nothing much to add, to be honest. I had the privilege privilege of working with Dr. Francine in the past, and I'm not really surprised to see all the hard work she's been doing. And I know how difficult it has been for her, not only to go through her exceptional training, but also to establish this registry. And I'm really glad to see the team working with her. No specific things to add, to be honest. Just appreciative of all the hard work done. And I really think that as a diaspora, it would be good for us to keep on gathering and making sure that we lend a supportive hand to that hardworking team. Thanks.
Thank you so much, Dr. Nute. Probably final thoughts and words from Sydney as well.
Yeah, I think I just wanted to reiterate what Dr. Sam was talked about. I think we live right now in a very special time where we have a great opportunity to make a change in Cameroon in how healthcare is delivered. The town hall is bringing together a lot of professionals, and I would like to call on everybody here to take full advantage of it. And with having the ears of the Ministry of Public Health right now, with all the people that are working on this team, we should not let this opportunity pass us without us having some major solutions, major achievements to show for it. Please take full advantage. We started doing training in Kouya last month, and we're going to continue to do training for general radiography. And that all happened thanks to the town hall. So let us take full advantage of it.
Thank you so much, Sydney. And I think without any further ado, I think we would probably love to hear some final words from all the team members who presented from Mbingo today before I go back to the moderators to close up. So I will call on maybe Alberic, who I know very well.
Okay, thanks so much, Dr. Jabukate Jean-Claude. I think it's been an opportunity meeting you again on this town hall. I think we last met even so many years back. So I think it's our pleasure to present what we are doing at Mbingo with so much dedication, with so much heartfelt towards increasing the care of our patient. You know, one of the major challenges I face as a pharmacist working in oncology is always on drug availability. It's true on the various aspects. We are looking on how we can better support the diaspora, can better support us back at home. I think there are some results that from our research that we are doing, we are not able to replicate some full data compared to other countries that are carrying out same twinning research programs, and partly can be blamed on the quality of the medicines that we have in our circulation in our market. So if there's a way we could also have a plea, which we could collaborate on that, maybe with the diaspora, on ensuring that what we have are also of quality, because there's so much happening in the African market. So with that said, we look forward for more collaboration with the town hall team and with Dr. Muno. I think we have been having some chats with him on the MDT team. So it's a pleasure having all of you, and it's also a pleasure for us to present what we are doing. Thank you.
Thank you so much, Alberic. I think we were all amazed, me especially, to see the number of studies that are actually ongoing within the program. And so really courage to you. I'll call on Ghislaine.
Thank you, Kate, for giving me the floor. I think I already talked my last word and I was talking about the challenge in imaging, so I don't have something to add. Thank you.
Thank you so much, Ghislaine. I think Brian, I don't know if Brian is still on. Yes.
Yes, I'm on, yeah. So I just want to appreciate everybody for this time. We've been able to share the different experiences we've had, and we are looking forward to see that we will all work as an entire team to improve cancer care in Cameroon, and most especially when it comes to cancer registry and data, because data is what will show that they're doing work too. Thank you very much.
Thank you so much, Brian. Dr. Kouya? I don't know if Dr. Kouya is still on, or probably network issues.
Yeah, probably, but okay.
Yeah, probably. Yes, so I'll go to Elvis and then to Mona to close out.
Yeah, thank you so much, Dr. Kate, for the excellent moderation for this very interesting session. You've made it really, really appealing to everyone to stay on till the end. I want to thank everybody also for always tuning into the town hall. We continue to grow this community, and we continue to count on your participation to make sure that our community continue to grow. And for the team at Mbingo, I want to say that continue to do the great work you are doing. This opportunity you've had to present to the town hall today, it's an amazing one. We are so elated, but to let you know that all our sessions are recorded, and we get them hosted on a YouTube channel, so it's gonna remain there forever. So a lot of people will go to watch this session. So don't think that the 60 or 70 you saw online is the only number. Each of our sessions gets viewed by at least thousands of people, because they have to view it either on our YouTube channel or on our Facebook page or directly online when we are live. So this is going to be a very important resource even for other people to know what work is being done in Cameroon. And for Aberic, I just wanted to also say that if one of our members of the town hall, Dr. Yauba Seidu, who is the country director of the Clinton Health Access Initiative, they are doing a lot of work to see how to help make cancer medication accessible, and they have really signed some deals with pharmaceutical companies around the world to offer prices for their medication at 50% discount for some countries, of which Cameroon was part of it. I know they are still working with the Ministry of Public Health to get a revolving fund that can get this medication to Cameroon. But if you see that the government is delaying, you can skip a step ahead and contact Dr. Yauba Seidu and see how your organization can directly start buying at that 50% discount rate directly from the pharmaceutical companies, because they get this deal signed already. And other countries like Nigeria are already benefiting from it. So we have a lot of resources in the town hall, but for all of you who are connected, one of the best moments to enjoy the town hall is during the parking lot, because that is where you can get people's contact, interact, and build connections. We've had a lot of really interesting connections that have emanated from the town hall that has led to so many interesting projects that are going on either in the country or elsewhere out of the country. So I encourage you to continue to be part of the town hall. And once again, we thank our chair for his leadership and for always making sure that we have these sessions every fortnight. So thank you.
Thank you so much, Elvis. Mona?
Well, Dr. Kate, thank you very much. I know I'm an oncologist and cancer is very dear to me. And I presently am in Santa Fe with my younger brother. He was listening from the back and he made a statement. He works in crowdfunding and all of that. He's like, can you guys not crowdfund for these guys? I'm like, okay, I'm gonna seek for your help if you're able to do it. So he got so touched with the presentation, and he's thinking about something I don't want to know. I'm just going to allow him to what he does. But what I can take out of this is that partnership is very important for the Mbingo organization, for us to get partnership. Those who are in the diaspora, if you're in any field in oncology, you should be willing to volunteer there. We should be able to collaborate and actually talk about what they're doing to different organizations. As we heard from Dr. Njok, there is a problem with sustainability over time. How are they going to sustain all these things they are doing? All these children who are getting free care. How is this in a system where healthcare is not free? And we also heard about what I call in oncology, maybe you take it from me, my residents know there are no tissue, no issue. If you have problems getting tissue, as the radiologist is telling us, they need help. They need training in order for us to be able to assess and get tissue from interventional radiologists. I know a lot of Cameroonian interventional radiologists that can actually help and train and also advocate to get our radiologists moved over to the US and other places in Africa and also in Europe for training. I think also improving the pathology department in terms of equipment and in terms of resources so they can get to do specific immunostaining so we can know from the onset and better. Dr. Francine, that I know very well, I've worked with her, she's a seasoned oncologist. I learned a lot from her too. They are able to treat, but at times we cannot even treat when we don't have diagnosis, when everything needs to be done in Yaoundé and even sent abroad, and it's expensive and patients cannot pay for it. Radiation. I think we have some solutions that can be proposed here, and people who can advocate also for Mbingo and also for the government. I think there are issues with us in the diaspora trying to advocate with the Clinton Foundation to get targeted therapies, immunotherapy back home. These are all things that people are benefiting here, but people back home cannot pay millions of dollars or millions of thousands for that. Palliative care is a cornerstone of oncology. And that's one thing that makes me really happy, because I trained in Yaoundé and I also worked in Douala, and that is what those teams in Yaoundé and Douala need to learn. You cannot treat oncology without having palliative care, without having access to morphine, without having access to medications that will palliate pain and other symptoms. Sustainability, where there is no data, then you are not doing anything. So I'm happy that Mbingo is actually carrying out research, Kate, and the cancer registry is the cornerstone of cancer. In Cameroon, we cannot say how many cancers we have, what is the prevalence. The data is not correct because we don't have a universal registry. Hospital-based registries are good as much as we can get out there and get a community registry that is going to be excellent. So I just want to thank Dr. Francine for her time, and maybe she's here now. She can give us her last words, Kathy.
Yes, of course. Welcome back, Dr. Kouya.
Okay. Are you getting me?
Yes, we can hear you.
Okay, so I just want to appreciate everyone for your kind attention and your time. And also, so really this your word were really encouraging to all of us. Because, you know, the notion that we have in Cameroon with the diaspora is that they just criticize, they just look at us as if nothing good can come out from this country. But today we have something different, that we have brothers who can encourage us and who can also there to support us so that we take care of ourselves, of our brothers and sisters. Last thing that I want to say here is that, you know, if we don't fix the system, we will be there one day. So if we don't fix it, one of us will be victim of that, or the system that has not been fixed. So we should better sit together and fix it, because if you don't, you are not the next person that will be victim of that system that is not well balanced. It will be your brother, it will be your mother, because not everybody has gone abroad. So let us fix it so that people will benefit.
Thank you so much, Dr. Kouya. And just to reiterate that we are all part and parcel of that system and already bearing the the crutch of the burden, the big burden of cancer in our society. I'm sure each and every one of us here has had close ones, members of our families diagnosed with one form of cancer or the other. And the burden is huge, the burden is growing in our country, Cameroon, and in other African countries. And we all really need to tie our belts and to go to work to try and fix what is happening in our health system. So really, I don't know if Mono, any final words? If not, then I would really want to invite all of us to the parking lot, which I guess would come shortly after this particular session. So thank you for listening right to the end with a very low attrition rate today, and look forward to the next session of the Cameroon Town Hall in 2 weeks' time. Thank you and God bless you.
end the session. And thank you everyone for being with us and for your time.